We have Dr. Sony SINHA presenting retrospective observational series on clinicodemographic profile of retinochoroidal colobomas.
Good evening, all. So there are no financial interests in my presentation. So RC coloboma occurs due to defective closure of the embryonic fissure in 0.5 to 2.4% per 10,000 live births. It occurs in isolation or with systemic abnormalities, and the phenotype is varied. The causes of visual impairment include refractive error, amblyopia, cataract, involvement of the optic disc fovea, and complications like lens dislocation and RD. So the present report encompasses the clinical characteristics of eyes with RC coloboma. This was a paucity of recent data, especially from East Indian eyes, and so by doing so, we aim to contribute valuable insights into the morphological features. So this was a retrospective records-based observational series of 82 case records of patients presenting with RC coloboma in the year 2024 in the Retina Clinic in the Tertiary University Level Teaching Institute of Bihar. So the clinical characteristics and systemic associations were tabulated and are being presented. The 82 patients had a mean age of 19, and they ranged from 3 weeks to 75 years. There was a predominance of children less than 18-year-olds in 60%, with commonest in 11 to 20-year-olds. The patients presented most commonly with the diminution of vision in about 70%, and about 1/5 of them were actually blind. There was a preponderance of males, about 60%, and it was a bilateral condition in about 63% of cases. One case had a contralateral anophthalmos, and the other one contralateral nanophthalmos with uncertain chorioretinal morphology. If we talk about the visual acuity in colobomatous eyes, which were 136 out of the total cases, we find that a moderate visual impairment was present in about 25% of the bilateral conditions and 14% of unilateral conditions, a severe visual impairment in 12% bilateral, and blindness after examination. Blindness was found actually in about 40% of bilateral conditions and 60% of unilateral cases. So if we classify this according to the Eiderman classification, we find that the commonest presentation was that of type 1 in 41% cases, type 3 in 17%, and type 5 in 12% cases. These are some of the represented photographs of our cases. So the associated ocular abnormalities were iris coloboma, microcornea, nanophthalmos, nystagmus, cataract and retinal detachment, strabismus, uveitis sequelae, lens coloboma, myelinated nerve fibers, disc edema, and unilateral anophthalmos in one case. So there were so many systemic associations. If we talk about the history, there was a history of HIE and developmental delay, prematurity, maternal drug abuse, antituberculous treatment, and gastrointestinal surgery. While syndromes associated were Golden House syndrome, CHARGE syndrome, a syndrome with club hand and hypoplastic left thumb, which we could not generalize, actually pinpoint association with microcephaly, with hearing loss, and with phrinoderma. So coming to the discussion, whatever studies that have been done in India regarding this have mainly pertained to the proportion of RC coloboma which are prevalent in either blind schools or amongst patients attending visual disability clinics or for visual handicap certification. Or there has been a study about prevalence of coloboma in eyes undergoing cataract surgery. But if we compare this present study to the largest studies that have been done in our country, both from L.V. Prasad Eye Institute, we find that that our study was comparable in terms of the commonest age group with the study of Das et al. And in terms of male preponderance, which was slightly more in our studies compared to the earlier studies. The bilaterality of the coloboma was also comparable with another study, which was done amongst the pediatric patients, while blindness was again comparable with the larger study. So, avoidable blindness, like, reasons for avoidable blindness, like cataract, were preponderant in our study, while as iris coloboma and microcornea or microphthalmus were comparable to the earlier studies, as shown in yellow highlight. The retinal detachment was, of course, very, very predominant in our studies, probably due to late presentation of our cases. The most common coloboma type was a type 1 in our case, while it was type 2 and type 4 in the earlier studies. So to conclude, more than 1/3 of the eyes are affected by blindness and about 1/4 present with retinal detachment. A high proportion of patients, especially children with visual impairment, cataracts, and retinal detachment is a cause of concern. Essential screening at birth and school entry must include fundoscopy to diagnose and treat causes of avoidable blindness associated with RC colobomas, along with visual rehabilitation. Thank you for your patience here.
Thank you.
24% of your patients had retinal detachment. And what are the difficulties you faced while doing the retinal detachment surgery for these patients?
Extremely difficult, sir, ma'am, because most of them were children. So actually, we are not doing retinal detachment surgery at present for very small children. So around 3/4 of them had to be referred to a center which was doing it.
And did you do a prophylactic barrage to any
Yes, we
patients?
did. We did.
What criteria did you follow to say that this person needs a prophylactic barrage around the coloboma?
Okay, so if we felt that the other eye had retinal detachment, definitely, if it was a bilateral case, we went in for a barrage. Then again, if we felt that, okay, this was an intercalary, the thinning was there, and maybe this will go into a break and then go into retinal detachment, we did do a barrage. A few barrages had to be done because there was a rhegmatogenous, possibility of rhegmatogenous retinal detachment because of a peripheral atrophic hole, peripheral hole present.
That's a different thing. I'm asking around the coloboma, just pertaining to around the coloboma.
Most of these cases.
You can follow them up with OCT on the coloboma.
Yes, definitely.
To look
we
at
did.
the ICM.
Yes,
Once the ICM detaches, that time you can
definitely.
go in and do the barrage.
Yes, we are following up those patients. Thank you.